Good afternoon to folks who are joining today's session of Arizona Community Grand Rounds. We will get started in just a minute or two. Thank you for joining. As you can see on the screen, we're looking forward to a great presentation today by Dr. Cindy Martin, who I will introduce in just a moment. As folks are joining, and before we introduce Dr. Martin, today's presenter, just a reminder to anyone attending, if you're not aware that recording of today's session, as well as recordings from previous Grand Rounds, since their initial implementation back in spring of 2020, are available on the NARBA Institute website. And during the course of today's presentation, as a reminder, Jen Pierce, who supports us behind the scenes for these rounds, and thank you, Jennifer, for that support. We'll put in a link to that so that you'll have that available for you. So Dr. Martin, I think we will begin. At this point, I know folks will be joining, coming from clinic and other types of sessions and activities that they have, and things that go on in everyone's very busy daily lives. But welcome to October 2021. I had to think about that for a second. October 21's edition of Arizona Community Grand Rounds. These rounds are sponsored and co-hosted by the NARBA Institute and Health Choice Arizona Blue Cross Blue Shield. So thankful to my colleague, mentor, and friend, Mary Jo Gregory, President and CEO of the NARBA Institute, for her leadership in founding and continuing to support these rounds. And so thankful to all of you for participating in rounds that we have month to month. Topics are selected based on emerging priorities that many of you share with us and folks that you'd love to hear present. And we are building the calendar for next year, which we hope to release in the upcoming few weeks, at least the next 4 to 6 months, because sometimes circumstances change rather quickly on us, and we want to have topical presenters. And we're so fortunate to have presenters like Dr. Martin, who are colleagues of ours and friends of ours and live and work in Arizona, to be the mainstay of the presenters that we have joining these rounds. Very quick note of housekeeping. That your phones are on mute, but we'd like to hear your voices through the electrons, and you're more than welcome to enter in questions in the Q&A and chat. And during the course of Dr. Martin's presentation or at the end, we'll do our best to get those questions to her. So I will do a quick introduction for Dr. Martin, whose bio and background are quite extensive and impressive. But I'll begin by saying that Cindy's is a friend, and I cherish that friendship. I've known Cindy for a number of years in some of our collective career paths in Arizona. She's a triple boarded physician. There aren't too many folks you're going to meet with that distinction. The board certified physician in multiple specialties of pediatrics, internal medicine, and palliative care and hospice medicine. Who also serves as a transformational fellow for the NARBA Institute. Dr. Martin began her career on the Navajo Reservation at the Fort Defiance Indian Hospital when it was under Indian Health Service governance, today known as the Seotso Medical Center. And she's worked the last 17 years in different hospitals and clinic environments in Flagstaff, Sedona, Cottonwood, and Northern Arizona. Her service includes other activities outside of her clinical work, such as previous and past president of the Flagstaff Medical Center medical staff, past chair of the hospital, the Flag Medical Center Ethics Committee, and currently she serves on the board of the Flagstaff Symphony and is a long-term Girl Scout leader. I did not know that, Cindy. Among her different awards and recognitions, that she was elected the Physician of the Year in 2011 at Flag Medical Center. Cindy's bio just notes that her passion continues to be fueled by the knowledge that all people deserve compassionate care and the honor of being allowed to participate in that care for her clients. So Dr. Martin, thank you so much for joining us today, and I'll turn the session over to you.
Thank you, Mark. So good afternoon, everyone. I'm so pleased to be talking to you about something that I'm passionate about, which is palliative care. If you're in healthcare, likely much of what you do is caring. And today we'll talk about the specialty of palliative care. We're going to be broaching some challenging emotional topics. So I'm going to start this slideshow and we'll pay attention to the next slide. See if I can get this to work.
Yes, and while you do that, I'll just remind folks that, again, you can hit the chat or Q&A button if you have questions for Dr. Martin. And please feel free to send me at any time your suggestions around future presenters.
So are we sharing?
We're not. That's why I was continuing to doggy paddle with my comments. And if in doubt, there you go. A share is coming up, Cindy. Okay, thanks.
Okay, we're sharing now.
Perfect. You're perfect.
And I should add that one of the additional skills on Dr. Martin and all of our CVs is the ability to share in different formats, such as Zoom. So
all right.
Thank you, Cindy.
Thank you, Mark. Okay. Is it sharing now? Because mine is moving, but it doesn't look like it's.
No, you're sharing. I'm sorry.
But then we have slide.
You haven't moved. Yeah. Hey, if you get stuck in this, and thanks for folks who I'm sure many are smiling because everyone's experienced this on their own. You could send them to Jen and she could advance for you too, if that would be helpful.
Jennifer, I did this earlier today and it worked beautifully. So the fact that it's not working now, I'm gonna send things to Jennifer.
It is, it's Murphy's Law. Once we go live, all the gremlins come out.
As long as it's Murphy who's not part of this. If it were Carol's Law, I'd be a little worried, but. And then when you send them over, we'll bring them up, Cindy. And I know what it's like to have a slide deck together and then try to remember when they don't pop up in front of you what you had as your first slide.
I know it, but you just have to see it for you to get the joke. And I'm having actually tachycardia right now because
no, so don't do that. So while you're doing this, and Cindy, you work in stressful clinical situations every day. Hey, Mary Jo, any thoughts, reflections from the NARB Institute on kind of where grand rounds may be headed in the coming up in the next year?
Absolutely. Thank you, Mark. We are looking to see if we can do 4 of the next 12 Arizona Grand Rounds with national speakers. Think folks like Dr. Don Berwick has been asked. We've tried to run the gamut of where we saw the interest in the former 12 series and what has kind of been learned in the meantime. And one of the things that has been strikingly clear is the interest in pediatrics, adolescents, both on the mental health and the physical health side, as well as continuing inquiries on the science, bench science, as well as practical science on the vaccines, emerging therapeutics, things like that. And so Mark and I have embarked on an effort with colleagues that we've known over the last, the earlier part of our careers, as well as the last 18 months that we may have known, and pursued it that way. We'd be very eager to hear your perspective, though. So if you find that you have folks that you know that have spoken at conferences or in other things that you've been involved in, we'd be delighted to have your update and suggestions.
Yeah, thanks, Mary Jo.
I have the slides ready to go. Are you Is everyone good with that?
Sure.
Okay.
Yeah. And we saw a tease of the slides there for a second. Oh, there they are. Now, Cindy, all you have to say, and our support for you, and thanks very much, Mary Jo, is next slide, please. And we should hopefully have that covered for you.
Okay, sorry about that, everyone.
No worries.
Thanks. So we're at the palliative care slide, and then the next slide should be parts of elephants in the room. Jennifer?
We are there.
Okay, so now imagine that you have a fuzzy elephant that you can hold on to. I want you to hold it to your chest because we're going to be talking about some really some difficult things today. If you start to get anxious, you can pet the specific parts of that elephant that are causing you distress. Some of us have bigger elephants than others. And if you don't think that you have an elephant at all, you should probably look behind you because it may be bigger than you think. So parts of the elephants are, avoidance, feeling awkward, feeling like silence is going to make things better, which it generally doesn't. When we talk about palliative care and chronic illness and end of life, we just have to really be open. Next slide. So Atul Gawande is a wonderful surgeon and author who has written Being Mortal, Medicine and What Matters in the End. And his statement, our ultimate goal after all is not a good death, but a very good life to the very end, I think is so pertinent to what we do in medicine. Next slide. So our overview for palliative care. The Webster Dictionary definition of palliation is to reduce the violence of a disease, ease symptoms without curing the underlying disease. And the World Health Organization definition of palliative care states that it provides relief from pain and other distressing symptoms. It intends neither to hasten nor postpone death. It affirms life and regards dying as a normal process, integrating the psychological and spiritual aspects of patient care. Palliative care enhances quality of life and may positively influence the course of illness. It offers a support system to help patients and their families live as actively as possible until death and to cope during the patient's illness and in their own bereavement. It uses a team to address the needs of patients and their family and is applicable early in the course of illness and in conjunction with therapies that are intended to prolong life, like medical treatments, chemotherapy, and radiation therapy. Next slide. Is this the what is palliative care slide?
Yes, that's where we are. Thank you.
Next slide. What diseases qualify for palliative care? Essentially, any disease which causes a chronic and progressive loss of function and interferes with daily life. Palliative care is a relatively newly named specialty. In some ways, it is born of the proceduralization and specialization of medical care, of the ability to treat in so many ways, some of which do not have a clear benefit as a patient becomes older or more debilitated. Chronic illness has changed with the view through the palliative care lens. Next slide. So old versus new. The old version of chronic illness, palliation, and hospice would it be that people were to receive life-prolonging chronic illness care until they reach the very end of their life. And then they would enroll in hospice. The newer version is that people receive life-prolonging care and then receive progressively increasing support from palliative care until hospice care seems most appropriate. In this manner, people can receive life-prolonging care and palliative care with aggressive treatment for a longer period of time. And that supportive care can begin in any stage of the disease process. Next slide. So how is your crystal ball working? And it can be really difficult to prognosticate in a disease process. how someone's going to do, because we're all individuals, we're all different people, and there is no crystal ball when looking at chronic illness and end of life care. What we do know is that disease trajectories can be somewhat predicted. Next. So disease trajectories, when talking about a disease trajectory or how a person will function with a specific disease, it can feel a bit like pulling an answer out of a hat. There's a specific art and science to predicting the course. So when looking at a disease trajectory, sudden death is if someone were to say have cardiac disease and have a massive heart attack. They would have a high function until the end of their life, which would come quickly. A terminal illness, which is in the top right of this slide, is more like a cancer diagnosis, where people will have a high function for a prolonged period of time. And even after the diagnosis, they may have very high function and be able to do all the things they used to be able to do. But as the cancer progresses and or chemotherapy makes them weaker, they can have some remission that the cancer may come back or continue to grow. People tend to have a chronic decline over time with a terminal illness like cancer. With organ failure, and this can be heart failure, lung failure, or kidney failure, people tend to have a relatively high function, which declines over time. So they may have a dip where they go into the hospital. They don't generally come back to the same place that they were before. So they may have a little bit of a decline where that they aren't able to come back to. So they have multiple hospitalizations generally over years or maybe even decades until ultimately the illness causes their death. And the last is the bottom right, which is frailty, which tends to be what we see with old age or dementia, where people have a lower function over time, and that function just progressively declines. They don't have big dips in function, but they also don't come back to a new and better baseline over time until the end of their life. Next slide. The tools that we can use to prognosticate are many, actually. And some of them have been just around for decades and decades. One of those is the Palliative Performance Scale. This is a very busy slide, so don't feel like it's not something to try to really focus on. But what it basically says is on the far left-hand side, you know, a PPS or Palliative Performance Scale of 100% is someone who's functioning very well. Generally, probably like you and I do every day. We're able to walk or ambulate, where our activity level is normal. We're able to perform all our activities of daily living or self-care. We're eating well, and our level of consciousness is good. But as people have disease processes or chronic diseases, their ability, their PPS may decline. So, you know, someone who has cancer may progressively decline so that they're still able to walk, but they're not able to do all the things that they used to do. They show evidence of disease. They may not be able to work anymore because they just don't have the energy, or they get too short of breath. Over time, they may eat less and have weight loss. And over further time, they may have developed confusion or become bedbound. Generally, with a PPS of 70%, that's about where people can receive chemotherapy. If they're not able to walk into the oncology office, they're probably not strong enough to receive chemotherapy. And those are the things that we look at with palliative care. We want to help people have as good a life as possible, but understand where they are. We want people to be able to tolerate chemotherapy and not have chemotherapy actually hasten their death. So they have to be well enough to receive it in the first place. Next slide. Why is palliative care important? Well, palliative care simultaneously improves quality and reduces costs in healthcare. Palliative care creates a best value, meaning that people can receive the most benefit from the care that they do receive, and they can make good decisions about what care is best for them and the care that best coincides with their personal goals. Palliative care also addresses that concentration of risk that a small subset of the population who's reaching the end of their life can cause high spending, but more importantly, it doesn't provide good benefit. 70% of Medicare costs will come in the last year of a person's life. And I'm not sure at that point, well, I am sure, that's what I do. I don't think that always is for someone's benefit. So it's really important to be able to look at the care that's being offered and make decisions that will have as good an outcome as possible. Next slide. Known statistics. You can read these statistics. They're basically saying we have 90 million people living with serious illness at this time, and we're likely to have more as the population ages. Essentially, on average, right now, a 65-year-old person can expect to live another 19 years. And what do these statistics mean? It means we're going to have a lot of people in the future who are going to have a lot of illness in the future. I want to talk about prevention, preparation, and risk. Next slide. So lifetime risk. Well, the lifetime risk of a woman developing breast cancer is 1 in 8 people. The lifetime risk of a man developing heart disease is 1 in 4 people. Lifetime risk of diabetes, 1 in 6. And the lifetime risk of dementia is 1 in 7. So there's only one process up here that has a 1-to-1 ratio. We all know that we're going to pass away at some point. Death is not a bad outcome. It's not a failure of medical care. It's an expected event. So how do we prepare for that event? How do we garner support for that, quote, outcome, unquote? Next slide. Well, we do it by preparing ourselves, right? We prepare when we go on a trip. We prepare when we want to study or have an exam. So I think preparing for end of life is really, really important. The palliative care team is the professionals who are listed here. I just want to be clear that palliative care is provided in the years and decades up to people maybe needing hospice. So we have lots of time to prepare in our lives, even starting with where we are right now. But certainly as we grow older, have more chronic illness, have more, have debility in our lives, we should really be thinking about what we want the end of our life to look like. Next slide. So palliative care and hospice are different. I love this Venn diagram because it best delineates how palliative care and hospice are related. We'll talk more about hospice in a bit, but I just wanted to make sure that everyone has a clear understanding that palliative care is in the decades and years before end of life, and hospice is usually in the last 6 months. Comfort care, which is that small circle there, is focused exclusively on comfort and is generally provided at the very end of life. That can be provided in the home, it can be provided with hospice assistance often, or it can be provided in the hospital. So Dame Cicely Saunders was an English woman. She's the founder of modern day hospice. She first trained as a nurse and then as a physician in the 1950s. She wrote an article arguing about a new approach to end of life at the time. She stated that healthcare providers should provide, quote, care where they cannot heal. They should keep the patient's own struggle within their compass and bring hope and consolation until the very end, unquote. She was a foundation of modern hospice tenets and introduced the idea of, quote, total pain, unquote, which included the physical, emotional, social, and spiritual dimensions of distress. In 1967, after years of fundraising and promoting awareness for end-of-life issues, she founded St. Christopher's Hospice in Southwest London. She directed that hospice until 1985, so for 18 years. And ultimately, she died of breast cancer 20 years later as a patient at St. Christopher's Hospice. While Dr. Cicely Saunders was working, that was around the same time that Dr. Kubler-Ross in the United States was developing her 5 stages of grief. A lot of work on end of life was being done at that time. Next slide. Hospice benefit. So hospice is a Medicare benefit in the United States. It was enacted in 1983 to assist people in end of life. Hospice is paid a per diem, so they're paid daily for caring for patients, about $275 a day. That payment pays for nursing care, medications, durable medical equipment like DME. It covers the salaries of the chaplain, the social worker who provide visits and support to patients and their families. Generally, there's no routine office visits, and nurses will come 2 to 3 times a week to provide care, and a nurse's aide will also provide 2 to 3 visits a week. But the day-to-day care is generally by the family. Next. Most care with hospice is provided in the home. I guess I should say most people who receive hospice in the home. Hospice can be provided in a nursing facility or in a residential hospice. For hospice to occur, there's no order. I mean, a family member can call hospice and enroll in hospice, enroll someone in hospice, a patient can enroll themselves, or a person can be referred by their physician or nurse practitioner. A physician must certify that survival is anticipated if the disease trajectory continues its expected course for about 6 months. A person can stay in hospice more than 6 months. In fact, I've had a patient in hospice for years, up to 5 years. Generally, those are patients that have a very slow decline, but are demonstrating that they continue to suffer from a chronic illness and have a likelihood of death in the near future or the next 6 months. Next slide. The face of chronic care and end-of-life care is changing, though, I believe. In the past 20 years, there's been a focus on end-of-life care and on chronic care management. Aetna recently piloted the use of open access hospice, which is really palliative care in a home setting, where cancer patients were able to access home hospice services while getting aggressive chemotherapy and radiation therapy. This resulted in increased enrollment in hospice and decreased the number of inpatient hospital stays. Ultimately, it doesn't matter what you call it. Palliative care or open access hospice, where people can still receive aggressive treatments while focusing on enjoying their life, but recognizing they are having great further debility, results in better quality of life. How else is chronic care changing, or how should it change? I believe that the next huge hurdle is embedding palliative care into mental health care. Next. So this is no surprise to people who work in mental health. People with serious mental illness, or SMI, experience a much greater risk of death. The standardized mortality ratio, so I'm going to do a little kind of study talk. Standard mortality ratio, it's the ratio between the observed number of deaths in a population and the number of deaths that would be expected. So if the ratio of observed to expected deaths is greater than 1, there is said to be, quote, excess deaths in the study population. Usually there's a reason. In this case, we're talking about mental illness. So a person with SMI or serious mental illness has a much greater risk of dying from cardiovascular disease, cancer, and COPD or emphysema than the average population. That's not a surprise to any of us. In 2019, a study out of Columbia, who had partnered with the New York State Psychiatric Institute, published their analysis of data. It showed that inadequate screening tools, payment mechanisms, workforce shortages, and legal and privacy issues were barriers for mental health patients when they had serious illnesses. Their care was siloed. There was high healthcare costs and poor outcomes. And one of the contributing factors was felt to be the limited interaction between the physical medical health providers and the behavioral health providers. So I think for me, this is a place that I see a great need and focus for the future. I'm going to switch gears a little bit. We've talked about preparation a little, and so I want to talk more about preparing for end of life and why it's so important. Okay. So this information, this slide comes from a writer named Ron Ware, who wrote about her experience in helping people in the last 12 weeks of their lives. She wrote a book called Regrets of the Dying. I put this slide in here, not because I'm telling you to quit your job or suggesting that, or to call up an old boyfriend or girlfriend that you might occasionally think about and reconnect. I'm telling you because I want you to address any pieces of the elephant that you're kind of holding to your chest that may be hanging around. And one way to prevent regrets is with thoughtful preparation. Next slide. So this is a picture of my daughter and I, Rachel, when we hiked the Inca Trail in Peru, and that's Machu Picchu in the background. Well, that trip took a lot of preparation. We planned it out, we thought about it, we talked about it, and I think that's how we should approach our lives and our deaths. Next slide. So advanced care planning. We prepare, and to prepare for end of life, one of the things to do is advanced care planning. And I will talk about how to do it next. I wanted to talk this slide about what it does for us. It allows people to express their goals and their values. It communicates those goals and values to family members and healthcare providers, designates a healthcare proxy in the event of incapacity, and it's completed by documentation. So capacity is a term used in the medical realm to define whether a person is able to understand complex medical information and make decisions. Are they capable of doing that? Incapacity is if someone is not able to do those things and needs help. Other ways that someone might be incapacitated is if they're intubated, they're not able to speak for themselves. If they have an acute illness, which deems them not able to be responsive. In those cases, we look for the documentation that people have completed prior to coming to that state. Next slide. These are documents. And so advanced directives are these documents that are listed here. There are things that you can do at home or you can do with your healthcare provider. The first one's a living will. It's a written legal document that defines how you want to be treated if you cannot make your own decisions. It defines the care that you desire and that you don't desire. It would define whether you wanted to be intubated or to have chest compressions like CPR. It would define whether you wanted to donate your organs or whether you wanted an autopsy performed. whether you wanted to have a feeding tube if you could not eat, or whether you would want hemodialysis if your kidneys failed. It is key that whatever desires you have, however you want to be treated, that you discuss that, write it down, and discuss it with your medical power of attorney or your surrogate decision maker. That's the next document. That's a medical power of attorney, which is also called a durable power of attorney for healthcare. This is also a legal document. It names a healthcare proxy or someone who would make your decisions for you at times if you're unable to do so. Your proxy, also known as a surrogate, representative, or agent, to be familiar and have discussed your values and wishes with you, ideally. If someone doesn't define who they want their medical power of attorney to be, we turn to and are incapable of making decisions for themselves, we turn to Arizona surrogacy law, which states that the first person to answer for someone would be their spouse, unless they're legally separate. If there is no spouse, or if the spouse declines, then it would be an adult child. If there's more than one adult child, then the healthcare provider seeks the majority of children, a consensus of the majority of children. If there's no spouse and no adult children, then it would be the parent of the patient. If the patient doesn't have a spouse, adult children, or parents living, then it would be the patient's domestic partner. Fifth in line would be a brother or sister of the patient. Then would be a close family friend, or close friend of the patient. And then if the client has no one, then it can be the attending physician working with the ethics committee and other physicians. In summary, it's important to do living will and medical power of attorney so that we are treated as we would want to be treated, and that we have a person to advocate for us in the event that we can't speak for ourselves. The mental health power of attorney is a legal document that states that your designee can make mental health decisions for you if you are unable to speak for yourself. And if you're incapacitated, they actually could admit you to a psychiatric facility for treatment. A financial power of attorney allows your designee to pay your bills and access your bank account. The last document, the fifth, is a do not resuscitate order. And that is generally an orange form that's filled out by the client or patient and medical provider, signed by a medical provider and the patient, and generally will have a picture of the patient on it. It's placed on the refrigerator at the home so that if the medical services, EMS is called, that they would know not to intubate that patient, not to do chest compressions, to provide care, to place an IV if needed, to support and provide oxygen, but not to do heroic aggressive treatments. Next slide. So palliative care seems to make sense. It makes sense to me. I've dedicated my career to it, but there are barriers, and the cultural and religious beliefs that can be a barrier to palliative care can be either the patient's beliefs or the family's beliefs. I've worked with Native American families that have viewed speaking of death as inviting it, and so have to be very cautious about discussing end of life. There can be confusion about terminology. For example, hospice versus palliative care. There are a continuum of chronic health care and end of life care, but hospice is provided at the very end of life. There can be misperceptions about the intent and scope of palliative care. People might think that their disease doesn't qualify them for palliative care, or that that care might be administered only in centers like the hospital or a skilled nursing facility. There's a fear that palliative care will compromise access to costly and life-prolonging treatments. concerned that might be concerned that they couldn't receive radiation or chemotherapy, transfusions, antibiotics, or hyperalimentation, which is IV nutrition. Those treatments actually can be received while people are receiving palliative care, but some people don't realize that. Sometimes there's a mistrust of healthcare professionals, or this perception that end-of-life care is economically motivated, that somehow we're doing that healthcare rationing would occur. There's prognostic uncertainty and the psychology of decision-making, which if people have a trajectory where they're in and out of the hospital and they're progressively declining, but we don't know exactly when the end of life will occur for them. That can make it more difficult to know when palliative care is appropriate or when hospice care is appropriate. The psychology of decision-making too, because patients tend to be overly optimistic, believing that prescribed treatments will cure even incurable diseases. For physicians, the fear of causing harm by failing to do something can overshadow the fear of actively doing something harmful. There's also been studies that demonstrate that the closer a physician is to a patient, the less likely they are to be accurate when they're prognosticating end of life. Lastly, there's a lack of integration of palliative care into, I would say, many, maybe not most, but many healthcare systems, especially on the outpatient basis. Next slide. So this is meant to be funny, but sometimes it feels this way. We continue to treat people aggressively, even when we know that the end of life is very near. We're trying to do better. We've talked about barriers to palliative care, but let's talk about successes. There is a YouTube video, which I'd like to try to, Jennifer, I don't know if we'll be able to do this. I have to have you pop in and help me.
Give me 1 second.
Okay.
And Cindy, while she's working on that, just a reminder to folks that if you do have some questions for Dr. Martin, please, or comments, please feel free to enter those in the Q&A and or the chat. And right on cue, someone did that.
And this is a video that's put out by the World Health Organization. It doesn't have any words. It's kind of a feel-good video, but what I appreciated about it was that the World Health Organization sees encouraging palliative care as an international health issue and something worth advocating for. I think in the United States, we have so much that we can do that we're further removed by proceduralization and medical specialization from viewing end-of-life care. But in other countries, there may not be that same opportunity. And Jennifer, if we're not able to show this very short video, that's okay. We can move on.
Sometimes we can show the video, but the sound finds itself partly lost in the ether out there. So, hey, Cindy, might I just ask you, there's a question more personal. Your credentials are impressive. Why have you personally focused on palliative care with your 3 board certifications?
So that's a great question. I have always thought that relationships were the most important part of medicine for me. There's so much that we can do, but if we don't do it in a way that's caring and with good communication, then it's not good medicine at all. And when I entered medicine, I didn't have a lot of experience with end of life. that came as, I developed that as I practiced internal medicine and pediatrics. And I realized pretty quickly that to do it well, you had to have significant experience and really focus on it. And so it progressed over time. I obtained my palliative care board certification about 12 years ago. And it's a love. I mean, it's just something that I can't imagine not doing because it's so important. And I get a lot out of it. A lot of times people will tell me, I don't know how you do what you do with the team that you do it with. And I think it's the fact that we get to work as an interdisciplinary team, as a professional team, to wrap our arms around the patient and their family and give them amazing care and support at a really difficult time in their life. And I couldn't ask for a better job than that.
Thank you. Thank you for sharing that. Hey, may I ask you another question or two that's come in? And thanks for bringing the slides back up, Jennifer, or if you figured out a way to show the video. Let's go to the video, Jen, if you figured a way to do that, and I'll get back to those questions in a second. Thanks, Jennifer, for connecting to that. Thanks, Cindy, for sharing that.
It tears me up a little bit when I see it, but it's a really beautiful representation of what palliative care does and the team that works with folks. Couple more slides, and then I would love to field questions. So the successes, we talked about barriers, and to talk about successes, the prevalence of hospitals with a palliative care team increased 178% from 2000 to 2016, and the number of programs continues to grow. CAPC.org is a website. The Center to Advance Palliative Care has really worked to expand awareness of palliative care and is a great resource for all people of all walks of life who are interested in palliative care. Arizona currently has 16 hospital-based palliative care programs. Next slide. Northern Arizona. So Flagstaff Medical Center was one of the first 3 hospitals in Arizona to develop a palliative care program in 2010. That program now serves Flagstaff Medical Center and Verde Valley Medical Center patients, several thousand patients each year. It encompasses a developing program, outpatient program, which is in the clinic and for patients at home. Really proud of being part of this program. And the next question, and I don't have the answer to this, is where do we go from here? There's innovative palliative care programs across the country, none of which are addressing mental health in the way that I hope to do in the near future, or in my lifetime anyway. And there's an Optum California outpatient palliative care program that was launched focusing on data science models to identify patients more quickly based on their mortality risk, engage patients earlier in the trajectory, and have a care partner who's a hired surrogate family member or family member who's non-clinical, who would assist the patient and their family, sort of like in that video. There's texting to find the tipping point. That's out of Southwest Parkland Memorial in Dallas, which was using texting to engage with patients so that they wouldn't go to the emergency department, instead would text their team member, their palliative care team member, so that their care could be managed better as an outpatient instead of a lot of emergency department visits, which we know, especially during this time of COVID, is not a good idea for our critically ill, chronically ill patients. There's a virtually supported complex chronically ill patient service, and they were using virtual visits with training and workflows to provide access to advanced care planning and have conversations with patients, and while the patients stay in their comfort of their own home. So really just using telemedicine, but that was even in 2015, before telemedicine was as prevalent as it is now. And then there's novel programs for dialysis patients that the Verde Institute has worked with. We're dialysis patients, because we know that they're very ill patients and are on life-saving treatment of hemodialysis 3 times a week, which takes a great toll. How can they have better integration of palliative care to support them? Next slide. So, Buddhism states that the first noble truth is that we will all endure suffering of birth, sickness, old age, and death, and that it's unavoidable. Well, we've done the first part. We've all been born. Some of us have had some sickness, but the last 2 are unavoidable. So let's prepare for them and do it together. And last slide. Yes, Jennifer, thank you so much. You're fabulous. Last slide, the end. There's the light at the end of the tunnel. And happy to field questions.
Dr. Martin, thank you so much. Great presentation overview, and thanks for your dedicating your work, your career, and many aspects of your life to this important topic. A couple of different questions have come in. I know we only have a few minutes to consider them. One, someone shared an experience of the struggle with a family member to find services, and asked for thoughts around that definition and how clinicians think about if someone qualifies for hospice, i.e. there's relatively 6 months to go in someone's earthly life, and then whether there are any resources in the Phoenix area that you might be aware of.
Sure. So in the Phoenix area, there's multiple hospices and multiple palliative care programs. Often you can find, if you contact a hospice, they will be able to tell you about a palliative program that serves the area that hospice provides. Many hospices actually have outpatient palliative care programs embedded in them. I'm happy to provide additional information if there's any way that I can do that, like getting this person's phone number and contacting them. But I would say the first thing to do would be to call the hospice in the area where you are and ask them if they have a palliative care program, and if they don't, who they would recommend to provide palliative care in the area. Sometimes it's called supportive care or palliative care.
And so maybe just for folks who are participating today. If you do have follow-up questions, if you want to email me or Jennifer, I'm mark.carroll@healthchoiceaz.com, and I'll get you connected with Dr. Martin. And Dr. Martin, how about for students, medical students, people earlier in their career? Are there associations, groups of folks early in their career? How do they get connected?
So there's an American Academy of Hospice and Palliative Medicine, and then there's CATC.org. And both of those are great resources for palliative care and hospice. I know that most programs now for medical students and residents give exposure to palliative medicine. We currently, down at Verde Valley, we're working with a residency program and actually have started having conversations about trying to develop a fellowship program in the future in Northern Arizona. Also at Flagstaff Medical Center, there are students that are getting exposure to palliative care by doing a 2-week or 4-week rotation. Super important and a great time in your life to get exposed if you're a medical student or resident.
Yeah, absolutely. And maybe I'll just end with a final question and get your closing thoughts. Obviously, the past 18 to 20 months have been unprecedented in our lives and on the globe, and super challenging, and created all sorts of new opportunities for us to continue to learn how to work together and to understand palliation in the context of helping care for folks who are sick. Any perspective that you might share, both in terms of not just the weight, i.e. the heaviness of that experience, but also some insights into how we can all together move forward and support each other in the months and years ahead.
Wow, it's a heavy topic and a heavy experience, I think, for so many of us, in so many levels. I think it would take an hour to have a full, or more than to have a full discussion of what COVID has, because I think we're specifically talking about is what COVID has done to our community of healthcare providers, to our community of people, of patients, to those who've been touched. The fact that we haven't been able to have people come in and be with family members at end of life, whether they had COVID or didn't have COVID. I think there's a lot of traumatic experiences, and I think the word trauma may be overused at times, but in this case, I think it's very appropriate that there's going to be a lot of folks in the future who will be seeking support because of everything that the traumas that have been experienced during this pandemic. I think we've learned a lot as a culture, as a community, but there's ultimately, I think, I love the Stronger as One that the Norbit Institute has encouraged, because I think ultimately that's what we have to look to, that we're stronger as one community, that we're stronger as together, working together to face a pandemic than we are individually. And that as health in the hospital, that as a team, try to work with individual people and their families and provide support. We just have to do it as all together. But that's a very poor question. Or answer to the question. I'm so sorry, but
no, hey, Cindy, that's a beautiful answer in my view. It's hard work, first and foremost, to support people in challenging periods of their life, whether it's the end of life or during their life. So we commend you for that, but really commend you for that vision, and I thank you for that statement. That really just expresses, I think, what so many of us feel, which is, if there's one thing we've learned, it's the power of and the strength that we gather from leaning on each other and leaning in with each other. So thank you for that work. Thank you for the work that all of you who are participating today are doing yourselves in that And we look forward to continuing to do that together in the months and the years ahead. So Dr. Martin, thanks so much for joining us today. This will close today's session of Arizona Community Grand Rounds. Recording will be available as of next week on the NARB Institute website. If there are questions, again, that you didn't get to or I didn't get to, you submitted and I didn't see, please don't hesitate to send them to me and I'll share them with Dr. Martin and follow up with you. And until next time, please be well. Please continue to share and spread kindness. Thanks, everyone.